a continued discussion. Thank you. I would again thanks everyone on behalf of AppCom. I welcome all. I just want to say that as you are aware, the first CLM capacity strengthening webinar was held on 15th of May 2023, which covered the topic of the CLM concept, principles, and the steps for implementing CLM. The second capacity strengthening webinar was already held on the 26th of June, which covered the topic on CLM indicators, data management, analysis, and its use. Today, this is the third and the last webinar of the capacity strengthening activity. The webinar today is titled as Advocacy in the Context of CLM, and it will be running for approximately 90 minutes. The webinar today is led by AppCom, with the support of all the regional networks and in partnership with UNAIDS and with the funding support from CDC. The overall purpose of this webinar is to orient about advocacy, a general step for advocacy for the buy-in of CLM by the stakeholders. That's number one. Number two, contribute to strengthening the capacity of KP and PLHIV communities to build strong and sustainable CL mechanism at the country level, and to promote cross-learning and sharing of experiences and best practices to build buy-in and acceptability for CLM across the region. Having said that, without further ado, I would like to invite the first speaker for the opening remarks, Ika Novianti. Ika Novianti is from Indonesia and is a regional coordinator in Youth Lead. In her role as a regional coordinator, Ika oversees the regional programs and daily operations for the organization. Ika, over to you. Thank you so much.
Thank you, Selvan. Good afternoon. As Selvan mentioned, my name is Ika, the Regional Coordinator of Youth Lead Asia Pacific Network of Young Affected Population. I want to express my gratitude to the esteemed speaker who joined us today in this webinar. I also want to thank all the participants leading the CLM movement in the country. I thank the hosting team from AppCom and also the Seven Alliance for allowing us to gather on the same platform to discuss such an important topic, which advocacy in the context of CLM. This webinar is part of the series of capacity building, cross-learning, and several activities that Seven Alliance is implementing on CLM with support from CDC and also the UNAIDS RST. All these activities aim to strengthen the leadership of the regional key population network and also the national community organization in implementing CLM in the ASEAN Pacific. As you remember, the last two capacity building webinar were on setting up and implementing CLM from the ground and developing indicators, data collection and analysis. While for this webinar, we will focus on how to do the advocacy in the context of CLM. Most of us know that advocacy is crucial in the CLM cycle and that several challenges constrain effective CLM advocacy, such as the lack of awareness of stakeholders as community members, healthcare providers, and policymakers on the importance of involving community in the monitoring HIV and other healthcare services, leading to lack of support and governance into ensuring the CLM sustainability. Seven Alliance believe that strengthening community-led organization on effective advocacy is crucial, not just advocating for a policy change to improve healthcare service based on the CLM data, but also advocating to raise awareness with stakeholders and building an understanding of CLM. In this regard, I want to highlight young people's and youth-led organization vital roles in the CLM advocacy. Young people have a unique power that can be utilized in CLM, including CLM advocacy. We have been playing a crucial role in advocacy for equitable and accessible healthcare, promoting HIV education and prevention, and destigmatize HIV within our communities. We also embody diversity in terms of experience, perspective, and ideas. This is useful in the CLM work, where we can advocate to ensure HIV healthcare services are inclusive and addresses the different needs of community and individual. Since almost all the new HIV infection among young people in the region are among young key population and their sexual partner, it is only appropriate for young key population to be part of the solution. and the agent of change. However, Yankee population are constantly fighting for their seat at the table. As a member of this sector, I want to share that we still face barrier and to meaningful participation in the HIV response, including meaningful participation in CLM initiative because of the lack of proper support, such as mentoring and training and age-related discrimination. Engaging the youth in CLM nurture a new generation of leader and advocate. If we empower the youth and let them to use their tool of passion, creativity, and dedication, we can secure the sustainability of CLM in the region. I see a lot of young faces in the audience today. We also have a fantastic list of experts in advocacy. So I am hopeful we will inspire our young leaders to be the CLM advocate today. We will also have a cross-learning webinar tomorrow. Now, webinar tomorrow where we will have a dialogue with young leaders and hear their perspective about the importance of CLM in movement advocacy. I hope you enjoy the webinar and have a lovely day. Back to you, Sulfan.
Thanks so much, Shikha, for such a wonderful opening remarks. I really know that word, that advocacy is crucial for everyone, regardless of CLM or whatever, that is important for the policy change as well, for the key population communities. Having said that, I would like to invite the next speaker, Harry Prabal, my good friend. Harry is working as a programs manager in AP+ in Bangkok. He has vast experience managing several projects in Asia Pacific region on community capacity development. He is also the member of the technical working group of the Global Partnership to eliminate all forms of HIV-related stigma and discrimination. So he is actually going to talk about advocacy and its significance, advocacy and significance in Global AIDS Strategy Target, and its progress towards 10-10-10 targets, on how is CLM contributing to 10-10-10 targets. Harry, over to you. Thank you.
Thank you, Selvan. So can you put my slide, Selvan?
Sure, Harry.
Slide presentation that I sent to you this morning, or yeah. All right. So I'm gonna talk, as Selvan mentioned, I'm gonna talk about a little bit about the global initiative related to HIV-related target that that in line to support the global AIDS strategy. So last time, you already clearly explained talking about data, and then also in how to use, measure, and monitor using the data that are available. So, for example, we can also using the programmatic aspect from it, and also for many things that you can measure and monitor, like IBBS, the population of number of population, and also about the monitoring all the project that we've been doing it. So next slide, please. So for this one, I would like to bring back again these lovely pictures. It's talking about the global AIDS strategy from 2021 to 2026. Where this global AIDS strategy is really, they have a tagline very motivated for us, which is an equality framework that puts people at the center. There is also 3 result area that it can very clearly define in the global AIDS strategy, and also there's a cross-cutting issues, which is more include about leadership, country ownership, and advocacy, partnership, multi-sectorality and collaboration, data science, and many things. So next slide, please. So here are the HIV target, that the existing HIV target until 2030. So the first time we all aware that there is a 10-10-10-10, which is like less than 10% of HIV and key population experience stigma and discrimination. Less than 10% of HIV and women, girls, key pops experience gender-based inequalities and gender-based violence. And last one, less than 10% of countries have punitive law and policies. On the other side, we have the treatment cascade 95-95-95 target, which is it's about a number of people being reached, treatment, and stay adherent with their treatment. But then, as according to information that shared with Yayu, I just try to repeat it again. So there will be also another HIV related target for by 2030, which is the 30, 60, and 80s. This HIV related target is correlated to one to each other in order for us to able to end AIDS by 2030. So I just want to give a bit a highlight on what a global initiative that have been done in order to support countries to achieve the HIV-related targets, especially on the 10, 10, 10, and 3, 60, and 80. The next slide, please. So the first time I'm going to talk about global partnership. Global partnership, with the title very long, is the global partnership to eliminate all forms of HIV-related stigma and discrimination. So basically, this initiative was formed to inspire countries to take action to remove critical barriers to HIV services. And it was co-convened by community global organization and institution, like from the community side, we have the Global Network of People Living with HIV and International ICW. And also we have UNAIDS, UN Agency, and UNDP. We also get a lot of full support from the PCB delegation. And also recently, we just had also two biggest donors in HIV AIDS response, which is the Global Fund, and also PEPFAR is also joining the global partnership. The ideas of this collaboration and partnership is basically to harness the combined power of government, civil society, bilateral and multilateral donors, academia, and UN to consign HIV-related stigma and discrimination. So under the global partnership, there is a 6 priority setting that global initiative track is intended to work on, which is the community setting, workplace settings, education, healthcare, justice, and emergency settings. Now, the reason that why we become why we start to understand we start to understand why this setting that we've been more focusing, because according to evidence base, these 6 settings was the area that can increase access for key population and HIV to access the health services. So that's why these 6 priority settings become crucial. Then the many countries need to work on that direction. So in Asia Pacific, there is several countries that already been joined and committed, which is they have when they join, they have to identify 3 priority settings within 3 years and the next 2 priority settings within the remaining of 2 years. Those countries are Thailand, Nepal, Laos, PDR, PNG, Philippines, and Cambodia. So in support for country implementation on GP Global Partnership Initiative on stigma and discrimination reduction programs, at the regional level, we already conducted several consultation and workshop that include consultation and workshop on community settings. Basically, is we try to provide a platform for community to exchange information, strengthen their meaningful engagement, and propose effective and contact-based strategy. We also conducted with healthcare settings. This consultation was conducted between the regional organization like UNAIDS and APM+, and also we have the with the MOH from Thailand. And then workplace and justice setting, we work with the Philippines, and we also work with Indonesia for these 2 remaining settings. So next slide, please. So on the side from global partnership, there's also another initiative at the global level called the SCALE initiative, or most people know also PEPFAR UNDP partnership. The idea is with the title as the SCALE initiative, removing barrier to HIV services. The SCALE initiative is to help scale up innovative key population-led effort to address discriminatory laws and HIV-related criminalization in order to unlock access to service and accelerate progress on 10-10 target. The SCALE initiative collaboration and alignment with 3 components. The first one is focused on key population-led effort, and then the second component implement a pathway to law reform spectrum, and the third one is to elevate new and emerging people with HIV and key population leadership. So there's 3 components that will be more focused on the SCALE initiative. The scale initiative used four different tactics and approach based on the region context. For Asia Pacific, the discussion themes are based on different pathway to a legal reform, support people who use drugs, and legal support and community engagement. The countries that has been used for this scale initiative is Nepal, Thailand, Indonesia, Myanmar, India, Vietnam, and PNG. So the idea of being I'll try to explain to you about this global initiative on the HIV related target, which is 10-10-10 and 30-60-80s, is basically there is a push a global effort to support countries in terms of they are able to achieving the HIV related target by 2030. So the next slide has been, yeah. So basically, what we trying to do is like they, as a global trying to put some effort to support countries. So the same with the regional level, like we did with the between APN Plus and the other key population regional network with UNAIDS to conduct the consultation and the workshop on 4 settings, which is community setting, healthcare setting, workplace setting, and education settings. So that's the initiative that happening in the global in term of for us for countries able to achieve ending AIDS by 2030. Next slide, please. So that's all. Thank you so much. I hope I'm not over the time. So I give it to you. Give it back to Savan.
Yes, you did. 1 minute. Thanks, Harry, for walking us through the targets 10-10-10 and also 30-60-80, and also the initiative, community care settings, healthcare settings, and workplace setting. Again, for the participants, if you have any questions to the speakers, feel free to put it in the Dropbox or the chat box. Okay, the speakers are happy to answer your questions. Without further ado, I would like to invite Dominic Kemps. He is actually going to talk about the general steps for conducting advocacy in the context of CLM and how does CLM advocacy happen. So Dominic Kemps has been working with UNAIDS as a CLM technical advisor, supporting the global rollout of CLM since 2020. He brings 20 years of experience working as a donor consultant to and within community-based organization NGOs in the HIV, SRHR, and international development sector. Dominic, over to you. Thank you so much for joining us.
Thank you. Thanks, everyone. And I'm going to turn my camera off. Savan's going to share my slides because I'm actually in transit. But it's great to be with you all. I'm really happy to be able to present today. So let me just shut this off, and then hopefully my slides will come up in just a second. So I was asked to talk to you a little bit about advocacy, CLM advocacy, and pushing for positive change is how I've titled it. And I've got to be honest with you from the start. If I look at CLM programs around the world, the work around advocacy is I would say only getting off the ground. We all know that advocacy is often a long-term endeavor, right? And so some of the change that we'd all like to see happen tomorrow is still in progress. But having said that, let's move on. So the next slide, please. We've already gone through this. Harry talked about the targets, but I always put them in there because I think it's important to say that the UNAIDS, the global strategy, the political declaration is underpinned by communities. Communities are supposed to be delivering services, monitoring services, advocating for services and rights. And so it's really, really important that this work continues and is supported. Next slide, please. So community-led monitoring, this is just a definition again, because I know this is shared. I keep the definition in there so that you have easy access to it. I'm not going to go through it today, but it's, as you know, we talk about it as being an accountability mechanism, a structured platform, monitoring trends, and really, most importantly, it's led by those key and vulnerable populations who are most affected by HIV. Next slide, please. So you will have seen in some of the previous webinars, the life cycle, the CLM life cycle. And we've spent a lot of time and effort in terms of, identifying, where we implement, collecting information, getting our tools right, thinking about analysis. But then, we're only, in some programs, if you go to South Africa, they've got a highly developed dashboards and monitoring systems and reporting systems back into the health system. And I'll show you some examples as well of where there's been kind of higher level advocacy for change. But what I would say is that second half of the cycle, from disseminating information and particularly advocating for solutions, there are fewer examples that have come through so far. And what I mean by that is not that the advocacy or the feedback loop isn't operational or isn't working. It's just that if it's a program that's only a year or two old, the relationships are still being built. Sometimes when you report back findings, if you think about data collection and the analysis, and then you're reporting back findings after 9 months or 12 months after you first start, sometimes those are brushed off at first when first reported. But that's partly because the relationships are still being developed with kind of the local health facilities or whoever your partners are. So the bit that I would like to emphasize is that last bullet on the left, that when we talk about advocacy, I think there are two ways of looking at it. There's the advocacy that's kind of back into facilities, and I'll give you some examples in a second around how that is working and how I've seen firsthand in a couple of countries how that's working really well already, where there's quarterly meetings between the CLM team and their health facilities, and they're reporting data back into the facilities, and that's being adopted and services are being adapted. But also then sometimes higher level advocacy, government advocacy, and that, I'll be honest with you, I think we're further behind there. We know though that the contexts are very complex. Sometimes we've got issues with criminalization with certain groups. It's difficult to do that higher level advocacy. And we also know that from other projects that advocacy takes time. But again, we can look at a couple of examples in a second. Next slide, please. So here are some of those examples. This is taken from actually an ITPC toolkit on how to implement CLM. And one of the reasons you'll notice I've used this is because the examples actually date back a couple of years and aren't all HIV focused. And this goes back to my point where we're still developing the case studies around high level advocacy. But you can see here examples and outcomes for viral load testing in a couple of countries, tackling stigma discrimination. And this is one of the things that I've seen actually in a couple of country contexts. South Africa is another one where advocacy has really helped improve services. And I'll talk to you in 1 second about a very specific experience in Malawi, and then stockouts in Zimbabwe, and then access to HIV testing. So the key thing here is advocacy can be around anything, right? It depends what's coming out of the data and where the gap is. And so it's not going to be a cookie cutter because you see what's here listed in this table, this is what you will be advocating for. It will depend very much about what the data says. And I would emphasize that, re-emphasize that, and emphasize this again, is that advocacy messaging has to be focused on really clear asks that are supported by your data. So you can't predetermine what your advocacy asks are before you've actually collected the data, analyzed it, and have your results. It won't work otherwise. The advocacy needs to be found in data. And the second thing is the type of advocacy you're doing will be dependent on the relationships you have with your partners. So most often right now, that's with healthcare facilities. And in my experience, in the facilities that at least I visited or I've talked about with our country offices, there are strong relationships between the CLM partners, the community partners, and the facilities. And a lot of them are trying to adopt this model of performance management. So it's not so much advocacy like beating down the doors and trying to get a hearing. It's more like being invited to a quarterly meeting and trying to influence how the program is designed and implemented. I think that's really, really important, that when we talk about advocacy, it's not always kind of angry taking placards to the street, that sometimes it's actually sitting and presenting data and having a really thoughtful conversation with the partners about how they, about some of the challenges, but also hopefully hearing back from them why some of those things might be happening and what they can change and what might be difficult to change, because you might need advocacy further down the line to make the facility, some of it might be out of their hands if it's, for example, a stock out and the supplies are centrally managed at a national government level. So just really, really clear. You have to have really clear advocacy demands focused on data, and you need to, the type of advocacy you'll be undertaking will be dependent on the relationship you have with facilities. So next slide, please. There are challenges. I mean, sometimes you build up a partnership, but you're not meeting with the right stakeholders. This could be a challenge, and obviously for delivering the change. There's also, sometimes it's hard to develop your advocacy strategy in advance, right? Because you don't always know who you're going to be targeting, how they're going to respond, and what you're going to be advocating around. So I would always leave that as a bit of an evolving strategy. Put a structure or framework in place with some basic milestones, but something that is adaptable as you go. We know that funding is an issue, and a lot of these programs, for example, are funded by US government, which are year to year, and so we recognize that as a challenge. Sadly, it's also just a reality. But I would say, even though that is a challenge, we have to prioritize advocacy, even if it takes us across financial years, because otherwise you won't always get the change you need. And then that's related to time horizon. But we often think of time horizons which are far too short and in programming, and that's often determined by the funding situation. So those last two bullets are a little bit wrapped up in one another and a little bit outside of our own control. But even if the funding is year to year, always put together a plan, recognizing that it may take you beyond this year. Next slide, please. So the next slide is really around some best practices. And I guarantee that all of you are doing this in different ways. And it may be outside of CLM programs. And so it's just about transferring that trust and knowledge and experience into CLM. So engaging duty bearers and decision makers. So these could be the health service providers, this could be regional officials, it could be other community partners. Ensuring data is relevant and community owned. This is something that I mentioned earlier, but that community ownership is really critical. Fully funded, that is something that we as UNAIDS are advocating for on your behalf, and hope you will advocate too, but we want advocacy to be a key part of the CLM cycle, and that needs to be supported as much as the data collection. Technical assistance for advocacy, and this is the way that's framed here. This came from one of the CLAW Consortium's best practices reports. But the technical assistance for advocacy is, I think, also because often we're limited by the experiences we've had, and sometimes you're faced with a situation which is a bit new, and technical assistance can help bring experiences from other contexts into your context to help you. And so, it's one of the things through the TSM facility, I would encourage you to seek if you need. Solution-driven evidence-based advocacy. This is what I talked about earlier about data, work plans, which I mentioned earlier about having a clear plan and letting that evolve. Clear messaging, again, mentioned as part of that work plan. And then, the key thing here is that you also need a united front. I know that communities are diverse and there are various things that need to be balanced, but when it comes to advocacy and going into a ministry, or when you're talking about rights, things, a united front is obviously crucial, and so really, really important. And where the funds allow, really recommend also that there are dedicated staff for advocacy, because it's a full-time job. It's not an add-on, something that you just do, with 10% of the time. Next slide, please. So just a few things to help you. There is obviously the guidelines and principles, which gives you a structure and framework. And I know that you guys are following that as part of the support that you've received. There's the technical assistance I just mentioned through TSM, which also includes support for advocacy planning, and support to help deliver high quality advocacy. And then there are two documents which I've used for this presentation. So one is the best practices in community-led monitoring that was developed by the CLAW Consortium. And the other one is the how to implement community-led monitoring, which is an ITPC toolkit. You can see images of both there. And those are all easily available. I'm pretty sure you've probably had them listed before, but I can send links otherwise. But with that, that's kind of what I wanted to share with you. I think maybe I'll just give in 1 minute a case study of how I've seen this work really well. I was recently in Malawi, and I was visiting a faith-based clinic that was run by Catholic nuns, and this facility was a poor performing facility, which is why it was selected for CLM. And part of the poor performance was around key populations, particularly MSM, who said that they avoided the clinic because of stigma discrimination. Now, following literally one cycle of CLM, so it was about 9 months, results were fed back into the clinic through a government community structure called the Health Advisory Committee. And all this was fed back into the committee via the CLM team with data, strong data, with case studies, with community members actually speaking in the Health Advisory Committee to the nuns and the administrators, other administrators of the clinic. And they made the change. They said, we're here to serve our people, and we didn't necessarily understand how some of the things we were saying and how we had structured the services was being discriminatory. And that now is a well-performing clinic. And at least with some of the MSM that I was speaking to when I was there, it's their preferred clinic in the Lilongwe area. So a great example of advocacy is performance management, how that in that environment, the CLM program helped to really turn around a clinic very, very quickly. It won't always happen that quickly, but we always can hope. So with that, thank you very much for the time today. I wish you a great session. I'm really sorry that I'm going to have to run, so I won't be able to join any discussion later. But I wish you a good webinar, and I'll come back to start on.
Thank you so much, Tom. That's such a wonderful and comprehensive slide presentation. I really do know that evidence-based advocacy is absolutely very important for the buy-in of CLM at the country level. And also would like to say that some of the country partner organizations, the Asia and Pacific region, are also doing the quarterly meeting just to share the findings and the result with the stakeholders, for the buying in of CLM. This, I think, will be continued to ensure that the CLM buying in is happening at the country level. Thank you. Without further ado, I would like to invite the country partner organizations in next session, who will be talking about the CLM advocacy experience of successful advocacy action led by the communities in the context of CLM. So they are going to talk about the challenges and the recommendations, and also the role of stakeholders in CLM, and also the support required from the regional technical assistance provider and the stakeholders to institutionalize the CLM and also to sustain the CLM at the country level. So for this, I'm going to actually invite the first speaker from Bhutan. His name is Dhanraj Ray. Dhanraj Ray is working as a programs manager in Leksam in Bhutan. He is a focal person implementing the CLM since it was institutionalized in the country level. He had been working with Leksam for almost 6 years with the responsibility to implement the national and regional global fund grant. Dhanraj, the mic is yours.
Thank you, Salvan. Can I have my slide, please?
Sure, Dhanraj.
Thank you, Salvan. Am I audible, by the way?
You are. Go ahead.
All right. So I'm sorry I came to the picture in the last moment. Actually, this presentation was supposed to be made by our executive director, Mr. Wanda Doji, but unfortunately he has to go out with some other prior commitment. Sorry for that. So today I'll be presenting on the community-led monitoring, our advocacy effort, and the challenges that we encountered while having such involving the community in the CLM advocacy effort. So next slide, please. So advocacy, once we have the CLM report and when we are ready with the CLM findings and recommendations, we directly advocate to the Ministry of Health, which is our key stakeholders, because CLM is all to do with the quality of HIV related services, to improve the quality of services. So that's why the Ministry of Health becomes our key stakeholders here. So once we have this recommendation, we gather all the health providers who are involved in the HIV care and treatment, and then we try to disseminate our community-led monitoring findings. And then we also target the students who are currently undergoing the study in the Faculty of Nursing and Public Health, because the students, as you know, that they are the future health workers. So we feel that disseminating the findings, the recommendations to this group of people are equally important. And then we also disseminate our findings to the HIV positive members, and then their affected family members, in order to validate the findings from the CLM. So next slide, please. So in our effort to effective advocacy efforts, we do encounter several challenges, especially involving the community members in our advocacy efforts. Firstly, the majority of the HIV positive members in Bhutan are illiterate. So Bhutan, as you know, that the cohort of people living with HIV in Bhutan is small. In fact, from 1993 until now, only 794 people have been detected with HIV so far. So out of those people, almost 38% of them are illiterate. So it becomes very difficult for us to reach out the information, to involve them, and then disseminate the findings virtually. So this is one of the greatest challenges that we go through actually. So the other challenges is the geographic location and the season, of course, because the people living with HIV in the country is scattered all over the 20 districts that we have in the country, and then it becomes difficult for them, for us to reach out to them, especially in the data collection, and then because of the monsoons and the sub-zero temperatures in some locations, it really becomes difficult for us to meaningfully involve them. And then again, the majority of the PLHIV in the Bhutan are unemployed. As per the study that we carried out last year, we found out that 44% of the PLHIV are unemployed, which means that they just care to have 3 meals on the table in a day. So they don't care about getting actually involved in our community-led monitoring efforts. So, and then there is also no proper mechanism in place, especially whatever the recommendations and findings that we present to the Ministry of Health. We don't know whether it just lies on their table or whether they take any concrete actions or not. So because of this lack of this monitoring mechanism, we don't know whether our recommendations are taken into account and whether the appropriate actions are taken or not. So this is one of the greatest challenges that we face right now. And then the community-led monitoring, it's we don't seek ethical approval from the Research Board of Health. We consider it as a routine monitoring activity, programmatic activity. And then because of that, our advocacy efforts are just limited to the Ministry of Health, which means we can't publish our report in the journal. We can't use the findings out there. So this is also one of the challenges that we go through. And then the questionnaires in the CLM toolkit is just limited to the HIV-related services. Because the people come to other services as well, but the questions are just limited to the HIV-related services only. And then the last challenge is obviously is the resources, because we know that CLM is an ongoing process and it has to continue, but then it also requires stable resources, which we are worried, because the sustainability of this activity, especially in Bhutan, is not guaranteed, because we are still in the early stages of CLM. In fact, this is just our third phase of the advocacy in CLM, but then we are worried that once the regional brand phases out of the country, then we'll have hard time sustaining this activity. Next slide, please. So the key roles of this stakeholders, especially here, our stakeholder is the Ministry of Health. So their role is to, once we present our recommendations or once present our findings, they need to be quick to take the necessary actions and then report whatever action they have taken back to the community-based organization. So this is only one role that we have identified for now. Can you move to the next slide, please?
Then Raj, may I request you to come closer to the mic because there is some request from the speaker. They can't hear you properly.
All right, I'm sorry. Is it audible now? Am I audible enough?
Yes,
Hello?
I think better. Yes.
All right. So sorry about that. So the support that the technical assistance that we need from the technical assistance provider. So of course, a lot of efforts are going on right now. The community-led monitoring feedback mechanism is coming up, but apart from that, I think these are the key areas where we need the technical assistance. Firstly, we need community-led monitoring guideline, because as I mentioned earlier, when we present our findings, there's no a proper mechanism to monitor what goes on, and there's no clear roles matrix. So if we have this CLM MNE in place, then I think our CLM efforts will be benefited. So we also need to integrate our CLM findings in our organization's DBMS. So DBMS is the organization's database management system where we monitor the client's health and all. So what we are trying to do is, the 8 indicators that we have in CLM can be integrated in this DBMS, whereby the key stakeholders and whoever wants to view our report and findings, they can directly go to our web-based application, and then they can access the findings. So this is also one of the area where we are exploring technical assistance. And then we also need technical assistance in writing position papers, advocacy trades, and other IC methods for effective dissemination. And then we also need technical assistance in designing and planning our advocacies for better teams. So this is it, I think. Thank you, AppCom, for providing us the platform. If you have any questions, then I'll be happy to answer. Thank you. Over to you, Salvan.
Thanks, Janraj, and I really appreciate how you came in the last minute replacing Wangdaji, and it was very comprehensive, especially talking about the challenges very openly. And for the people who don't know, Bhutan is implementing CLM, and AppCom is one of the, AppCom is a regional SR partner providing technical assistance support to Bhutan for the Global Fund grant for implementing CLM for SKPA1, which is Sustainability of HIV Service for Key Population. And now in SKPA2. So our team is providing technical assistance support to implement the CLM. Thanks, Dhanraj, for raising that. And we also note your recommendation. We at the region level will continue supporting that to overcome the challenges. Without further ado, I would like to invite Sium Sofal, who is working in Cambodia as a programs officer in CNP+. He has vast experience in HIV and health-related work. He is also going to talk about the challenges recommendations in relation to CLM. Sium, over to you. Thank you.
Yes, thank you very much, Selvan. As you will be aware, since during these 3 years in Cambodia, we already start up with CLM implementation. Yeah. Selvan, did you hear me?
Very well, we can hear you.
Okay, yeah. So please give me the slide, please. Yes.
Sure. You want the Word document, right, to be on?
Yeah. The last one, the last one.
Sure.
Yeah.
Just a second.
Okay. Otherwise, can I read from here?
Sure, you go ahead.
Yeah. Yes, like you understand, in Cambodia, we already start up CLM for about 3 years already, since 2020, and also partially implemented during 2021 and full scale in 2022. Yes. Yeah. But the process of our implementation is very limited, because in Cambodia the contact of CLM is very rare and not well known to all like a stakeholder or NGO as well, but limited only to the scope of network of people living with HIV and KP as well. Yeah. So, but as even though like that, we still produce a good result. Like we have produced 7 links. Yes, 7 links that we share by online or by our network, and also just to the group of our KP network, and also with people living with HIV network. Yeah. Yeah. At the meantime, that result we also share to the technical working group of National Aid Authority as well, and also we use the result of our data collection from the CLM also to advocate for some service change, or some to improve the healthcare health service in the health facility, or also approach to advocate for some like a change or some law as well. Yeah. And beside that, so like a result and lesson learned, after we during this Q2 in 2023. Yeah. So like you understand, CLM in Cambodia, we already share for some time already, for a few time already, but so for today I just put that CLM at a glance. So like totally in Q2 in 2023, I just take for 2 links, that is a stigma and discrimination, and also PrEP. Yeah. So another 5 links I just maybe for next time. So stigma and discrimination during this Q2, we focus on about 36% reported experiencing stigma and discrimination in the last 6 months. While pivot is almost 100% that still experience stigma, and entertainment worker also 42.3%, MSM is 39.2%, TG also 22.2%. but for PL-HIV only 12%. In addition, 19% are reported not receiving equal service at healthcare facility within these last 6 months. Yeah. On the other hand, 27% reported feeling afraid to receive or to go to visit another health service because of the stigma and discrimination. Yeah. Furthermore, stigma and discrimination are still a challenge for KP as well. Yeah, based on the data here, we have around 19% experience stigma and discrimination. Yeah, that is for the stigma and discrimination. Yeah, but for PrEP, yeah, PrEP awareness also still limited to reach to KP. Why? Because of the scope of our implementation is very limited. In Cambodia, we have 25 provinces, but our work for CLM, we limited only to the fast-track city that have around 4 provinces and also included with 3 provinces more. So we have only 7 provinces that implemented CLM. So that's why our CLM data or PrEP is not so well aware about that. So based on the data on CLM, there are 31% of among 1,599 record mentioned that did not know about PrEP services available at health facility and CBOs. Yeah. Regarding the data in the dashboard, about 90% of entertainment workers did not know about PrEP services, followed by 67% of PVIT and 50% of PWOOD and 21% of MSM and 5% of TG. Yeah. More than that, we have 60% reported never using PrEP service. Yeah. And 20% under PrEP using still in using PrEP, and 6% is drop of PrEP. Yeah. On the other hand, about 59% of PrEP users were satisfied with PrEP services, and 38% were neutral, and only 3% were dissatisfied with PrEP services. So I just want to clarify that why the PrEP result here is a little bit low. Like I explained to you, because of our CLM implementation to the scope of limited to the area. Yeah, but we still have another PrEP delivery or PrEP providing to the KP with another provinces. But our CLM implementation not reach to that area. That's why the result is a little bit low. Yeah. So next, please. Yeah. Even though we still have facing with some challenges, but also we have a good result or good achievement. Yeah. Like KP representative had the great opportunity to present CLM dashboard to the annual technical working group of the National AIDS Authority that combine of all the technical or committee from 25 provinces. So we can have the opportunity to share about the result of CLM. So in late 2022, with key achievements and challenges raised by KP in the annual policy board meeting, like we said that prepared by National AIDS Authority. As a result, the government helped to scale up ID pool registration, not just to the people living with HIV, but also to the entertainment worker. Like right now, under the process to speed up how to support KPs and entertainment worker to receive ID pool. Yeah. But for people living with HIV, we already have a circular of from the government to provide for all the people living with HIV with the ID pool card. Yeah. The above result that we explain or we share during the annual board policy meeting but we still face with some challenges because of the stakeholder or because of the some local authority did not understand about the CLM. They not be aware about the CLM. What is the CLM doing because of our limited scope? Even though that we use the CLM to advocate during the
Siyong, I'm
yeah.
so sorry to cut you. I think you have to wrap up. We are running out of time. Thank you.
Okay, yes, during that, even though we have a challenge, but we have good opportunity to use the CLM to advocate during the country dialogue. And the result is we have like a global fund to put the CLM for the next funding process in 2024 and 2026. Yeah. So we do, in conclusion, this CLM in Cambodia, we will, if we have more funding, we hope that we can process in full scope of implementing in 25 province, but not that the promise from the global fund is around like 5 province more, include from the 7 provinces. Yeah. Thank you very much, Selvan, and thank you for pay attention. Yeah, thank you.
Thanks, Seyong, for sharing the wonderful experience of CLM in Cambodia. It's really good to know about the dashboards and also the recommendation, whatever you have mentioned right now. Of course, these slides will be shared with all the speakers for future reference and learning also. But if you have any questions, feel free to drop it in the chat box so the speaker can answer. So we are running out of time. Without further ado, I would like to invite Leslie Bola, who is from PNG, working as an executive director for the Key Population Advocacy Consortium in PNG. He actually oversees the implementation of advocacy program for KP and PLHIV in PNG. He, of course, will be talking about the challenges and recommendation and also the role of stakeholders in relation to CLM. Leslie, over to you. And thanks for joining us, Leslie.
Good afternoon, everyone. It's 6 p.m. here in Papua New Guinea. Okay, I'll go straight on the slide. So I'll be sharing mainly the experiences that we've gone through with CLM in the National Capital District in Port Moresby, that's in Papua New Guinea. Next. I show this slide because this is the backbone to the CLM program. We really have had our goal focus, and that is to improve coverage and quality of HIV other services in 4 communities. And under our goal, we have those activities. So most of you would have gone through this. This is from my experience having a clear objective and a clear goal. It also helps us to guide our funding, how we do our budgeting. So when we design our objectives, it really helps us to place where the funding goes into those. It helps us with our budget in terms of proper management of CLM. I won't go through that, but we have 4 objectives, and all of you know you've gone through those stages: the design phase, and then the implementation stage where we collect data, and then we go down to advocacy where we empower our communities to collect data and also give feedback to the facilities or policymakers. Next. So in the CLM in Papua New Guinea, we have 5 platforms. So the first platform, we have a national response center, and we have employed 3 staff who manage a telephone and the social media platforms like WhatsApp, Messenger, based in the NCD, and then people ring in if they have issues, they ring in, or if they want to inquire about PrEP or anything, they get information through the response center. We also, in the provinces, we want to engage the provinces. So the platform we use are mainly Facebook, Messenger, and WhatsApp. CLM 1 and 2, we've developed tools, how to collect data, document that, and then we have other very special tools that we use to monitor these 2 platforms. The third one is an exit interview. Anyone that exits a clinic they get interviewed through a scorecard. So this is done every quarter. It's a routine base. So after every 3 months, we have 9 monitors who have been trained with the forms that it's done manually, and 2 supervisors. So they sit in 23 health facilities, and they interview KPs that exit that clinic on that particular day. Community forums. This is another platform where there are lots of stigma, self-stigma around key population who don't want to access a clinic. So we call this forum so we can ask them, what are the issues? What are the barriers that they don't want to go to a clinic? And then we get the information, and it helps us also to give feedback to the community and also to the health facilities. So this is, we call it triangulation, how we can get information that we don't get from the exit interviews. And then the final one, we have a facility mystery client scorecard where clients go and do a general observation. The 9 monitors just do a general observation, and then they document things, and then they come back, and then we have a discussion around their observation. So those are the 5 platforms that we use in Papua New Guinea for our CLM programs. Next. I won't go through all of this, but I'm just going to highlight key highlights that we've achieved here. So for me, for the consortium, this is a homegrown intervention. It's previously our communities complained about things, but there was no structure in place. And now that we have a structure, we are collecting data, we're able to use the data to advocate for issues affecting communities. Also, we've really worked along with our leaders, and it's really hard when we're doing CLM. Some of the challenges is some clinics, they'll be thinking that we are monitoring them, but we've created that relationship that we say that we want to work together so we can improve the quality of services. So we've been accepted into those clinics when we do interviews, and that is support from our provincial health authorities. So they've been part and parcel of the beginning of the process, where we started the process by sensitizing them, buying in the program, all the way down to where we are today. Also, from the experiences from the platforms I've shown, we've really come up with some, we call them knowledge products, like tools, experiences, reports. So that's stored up at our library, at our website, the CAPEC website, so that if anyone wants to access that, you can see it. But we are really strong in documenting anything. Even the forms that we use, we have sort of 1 version to 6 versions. Those versions, we are fine-tuning it because we've gone through those experiences. And so we have them. So having, say, for example, a version 7, we've gone through that form and we've really fine-tuned the form to suit what the community needs. Capacity building, lots of capacity building around this. From my experience, it's more like research, but it's very high-level research. But we've really gone down to the community level where we empower our communities how to collect data, how to analyze data, and how to present. So my role is to ensure that anyone who gets that data is able to interpret it and relate back there to the communities or policymakers. Next. I just want to share this an experience. All these nurses that I'm showing here, they haven't got their pay, their fortnightly pay for the last 3 to 6 months last year, and they were working tirelessly. And we were the first one to appreciate the work they did in the community, so they were receiving certificates. So CLM has really strengthened our relationship by recognizing the great work they've been doing. Okay, next. Just 1 or 2 challenges that I want to share. As my other colleague has mentioned, our other colleague has mentioned, we really need to document the work we are doing so that when we leave, others can come and adapt those. So we really need a training manual of all the processes that we need to be done. Also, with the capacity of our KP members, the level of education, literacy level is very low. So everything we do, we really go down to their understanding. So very basic stuff that we do when we're delivering trainings and also building the capacity. Also with the CLM exit interview, we found out, we've done 3 rounds. We found out that the information we are collecting, it's similar to the previous one. There's not much major changes. So we are trying to look at ways how we can change that. Maybe we can cut down the number of times we go to a clinic. So those are some of the things we're thinking about now. Next. I won't say all of those, but this is our proposal. Because PEPFAR is helping us with our CLM. So at the beginning, there was delay of funding. So we tried to pick up some of we had to rush through things because of various factors. Some of the experience we have, like some of our volunteers that are on board, they tend to move on to other jobs or other opportunities. So we have to retrain people. So, and also the capacity of CAPEC's role in the HIV program. We really need to clarify that with the community because we're an advocacy organization and some people think that we are implementers. So we've got lots of clarity to clarify our roles. Okay, above all, our government, we really need to work closely with the provincial authorities in terms of sustainability. We want them to accept that, to integrate the CLM into the normal program so it's normalized. Okay, next. And way forward, we just have 3 suggestions so far. We need to improve our CLM 1 and 2. That's the response center. It's a new thing. We need to do marketing around it so that communities will know and also reach out to other provinces that we have. Also, relook at our CLM 3, as I said. At the moment, we're doing quarterly basis. Maybe we do it once or twice a year. And also we need to relook at our scorecards questions. At the moment, we don't ask questions around commodities. Our PLHIV communities have said, you know, how can we keep track of the stocks of ART? So we are trying to incorporate those questions into now so that we deal with real day life issues that communities face. Next. Okay. So I just want to highlight that this is an example of how we give feedback to our health facilities. All of us, the monitors, including myself, UNAIDS when they're available, and also the government, we all come and sit together with the clinic and we give feedback to the clinics. And we make it as a very participatory session. They share experiences, and then we document if they're really happy, we document special lines that they say, and then we highlight it in our website and we thank them. So the clinics are there, they work very hard, but CLM has really come into the space and really supported them as well in order to improve quality of services in Papua New Guinea. Next. Okay, thanks. I just want to acknowledge USAID, through PEPFAR, they are the major sponsor for this, and all our partners who are supporting us and the community especially. Thank you everyone for listening.
Thanks, Leslie, for joining us at 6 p.m. in the evening. It was great to know the good practices and the challenges from the CLM. I still can remember when we started the CLM in PNG, it was not easy, right? Because of so many challenges, especially the relationship with the stakeholders. I'm very happy to see now the relationship between the stakeholders is getting improved, I think. So kudos to you all and keep doing the CLM. We at the region level, especially the regional 7 Alliance Consortium, note your challenges. The challenges are training manual and capacity building and few other challenges, etc. So we know that we will be continuously building the capacity of the community partner organization, including the the KPAC consortium in PNG. Thank you. Now I would like to invite some questions. If anyone has some questions, please feel free to ask, raise your hand and ask, or else you can drop it in the chat box. Please feel free to do it. Otherwise, I can ask question to the speakers. Right now, I got only one question in the chat box, and that is, I think, for Sium so far. Sium, I'm going to put you on the spot. So the question over here is, in Cambodia, whether PrEP is subsidized by the state or provided by CBOs or out of individual pockets. I know you answered it in the chat box, but I think it would be good if you elaborated. Thank you.
Okay, yes, thank you very much. Like you understand, in Cambodia, ARV is before is funded by a full funded by a global fund, but right now is partial funded by a government also. But for in related to the PrEPs, PrEP is the new one in Cambodia, so all is funded by global fund. So right now, if we have 29 places to deliver a PrEP service in Cambodia among 14 provinces, but in that 29, we have 6 places is delivered or run by NGO as well. Yeah. So in Cambodia, but like we told you during the CLM, during I explained about the CLM, if we have expand or the scope of working area for more beside these 7 provinces, we will get more PrEP data. Yes, thank you. So I hope you got answer.
Thanks, Seung. My next question, I think I can ask Leslie, because Leslie and his team has done a wonderful job in terms of building relationship with the stakeholder. Leslie, if at all, if you want to give one suggestions to the CLM implementers at the country level, what suggestion would you give to them, especially for conducting effective advocacy for a CLM buy-in at the country level? Over. Thanks, Leslie.
So thank you for the question. When we first started CLM, I was a bit apprehensive because I wasn't really sure whether the health facilities will accept us, because what I heard was they thought that we were going to monitor them on the services they do and will be reporting them. So one of the strategies we use is when we were developing the questions, those indicators questions, we actually invited the health managers, key people within the clinics, and they were all part and parcel of us developing the tools. And then we refined it, so they actually knew the type of questions we were asking, and they contributed towards those questions. So in terms of creating the partnership, that started that way. So I thought it was a very useful learning. The buying in with the health facilities and even the government. Our goal is to get the tools incorporated into the health system, because they don't have any advocacy. They don't have advocacy tools inside our government, but our main aim is to incorporate that in. So we're slowly going into that. So I think at the beginning, it's very important. And then also, secondly, communication. We need to give back data consistently back to the clinic and also to the community and also to the policy makers, so they are kept informed of the whole CLM program. Thank you.
Thank you, Leslie. That's a wonderful approach, that you have to keep the CLM open and transparent since the beginning, right? So that's one of the things, so that we can build a good relationship with the stakeholders. So we are running out of time. I'm going to invite this second last speaker. But before that, okay, Rain, yes, go ahead.
Thanks,
Rain.
thanks. Wonderful presentations coming from Cambodia, PNG, and I think it's Bhutan or Mongolia. My only question is, somehow you were mentioning about technical assistance, and we know that technical assistance are usually coming from international and regional support mechanisms. I was wondering, what's the advocacy at the national and local level to seek and embed technical support within the countries? Are there discussions over that? How do we ensure transfer of knowledge into the local and national organizations to also lessen the cost of, for example, of technical assistance? Thank you. It's a question for all.
Anyone would like to answer that? Leslie, Seung, or Dhanraj?
Okay, thank you, Ren. I'll go first and then others can come. Ren, the buying into this intervention is very important. So one of the strategies we used was to involve the government so that they also be part of CLM. And then we're doing it indirectly, but when we come and ask them, One of the things we are beginning to do is to engage the M&E technical person within the department, so they're part of the program. So in future, when the funding ends, the M&E person will come on board and then support. So that's one strategy we're using. Yeah, thank you.
Yeah, thank you, Leslie. I just add a little bit. Yeah, in Cambodia, because of the CLM is quite new, and we try to promote and we try to advocate to the relevant stakeholder, especially to the government agency. So finally, we got support from the National Aid Authority that is very strongly support. That's why we have some successful implementation. But at the meantime, we also still need the technical support because it's in Cambodia. We could not find from the local in Cambodia, but only from the international like UNAIDS, DFAT, or HACC, or from the another NGO as well. Yeah, because our network is still a very limited capacity. Yeah, we still need strongly support technical. Thank you. Yeah.
Thank you so much. Of course, if there are more questions, please drop it. That would be really great. The speakers will be happy to answer. But without further ado, I would also like to say that, we are going to drop a link over here in the chat box. So here it is about the challenges and recommendations. So all are invited to include your challenges and recommendation in relation to CLM implementation at the country level. This would be on, we can also send this link to you later after this webinar. Please feel free to drop it, and that will be shared with all the regional networks over here, and that will be used for for building the capacity of the country partner organization. Yeah. So without further ado, I would like to invite the next speaker, Abina Ahir. So Abina Ahir is going to talk about the CLM sustainability. Abina Ahir is a popular transgender activist from India. Currently, Abina is working with APCOM Foundation as a community leadership, gender and human rights officer. So Abina, over to you to talk about the CLM sustainability. Thank you.
Thank you, Selvan. Thank you for the wonderful opportunity. And I would request Venice to kindly upload my presentation. Meanwhile, I just want to start with a very important learning for today. One is that I think the most important thing that I'm going to talk about is CLM sustainability. And while we talk about CLM sustainability, I think things that are coming to my mind very, very strongly. One is that this entire learning platform that we are learning from each other should not be stopping at all. And that is the backbone of sustainability efforts that we would do at the country level and at the regional level. The second thing that I can think about is the rich learnings that are coming on our way from these sharings that we are doing today. And thanks to APCOM, Selvan, and all the 7 Alliance who's taking the fantastic leadership in this regard to making sure that these learnings are reaching to our grassroots communities, which will help them to understand what exactly mean by CLM and how we can improve the CLM in future. And last thing I just want to talk about it is that the true empowerment that we are gathering, the true meaning that we are trying to derive from the CLM perspective that we are trying to bring in through our collective learnings. Next slide, please. So thank you so much. I'm going to talk about specifically around SKPA2 approach right now. SKPA2, Selvan already spoke about the extensive support that Selvan and everybody, Nikki is here, Nikki Sowandi is my colleague, and he's also here, and the fantastic work that they have done under SKPA1 program, where we try to reach out to multiple countries into our region and did their amazing system strengthening. And in SKPA2 also, we are going to continue the work that we are going with the CLM process. And what you see right now is the global front approach that we are talking about on CLM process very, very strongly. And these are the very important active mechanism that we are following. We are in a systematic scientific approach for us to engage in these countries for implementing CLM, so that we always measure the outcomes, the impact of CLM initiatives in our region with the country partners that we are having. Having said that, I just want to highlight a very important aspect about the sustainability of CLM. CLM is just not one-time process, right? We have started this part as a bigger approach on HIV epidemic, which talks about community system strengthening and health system strengthening. These are the two quite important aspects that we are from our CLM approaches in the region. And I think the more the communities learn to gather information, analyzing them, understanding them, interpret them, and act on it as an advocacy is an important aspect of the sustainability of CLM. Having said that, I also feel that there are two different wings that are, very important, strong link with the CLM. One is definitely the work that we need to put up on human rights, particularly on key populations through CLM. And second is that, of course, the larger work that we have to put up around young people and gender, because in our region, what we see it across, that HIV epidemic is concentrated on key population and young people, as per the latest UNAIDS data also, which was shared with us. So we are trying to empower the community. We are trying to increase the health outcome for the populations that we are dealing with. At the same time, the third thing is that we are trying to engage. We are trying to engage, like, for example, everybody here was talking about engagement of government people, right, within the systems, and especially healthcare providers who doesn't see CLM as a threat to them, but they see CLM as an opportunity to increase the health system strengthening. Next slide, please, Vanessa. Yeah, so in SKPA2 also we are working on a very, very strong principles, especially right now we are into the pilot testing mode, and we are doing this in Sri Lanka, Bhutan, and Mongolia, and we have already started getting first level of excellent learnings from all these countries. Thanks to our partner, Bhutan is also present here and doing a lot of work related to CLM. And a couple of things that we are trying to focus around with CLM right now is that how do we actually really follow up on serious response mechanism that people wish to take it forward for? How do we maintain the dignity of the communities which are accessing the health care services in our community? So that's a work in progress, and with our country partners, with the help of technical support of the APCOM, of course, we are going to strengthen this work more and more in the region. So some of the principles that we are extremely working around is that, how does that entire process becomes a community driven, and it has been driven by mechanisms within the countries which are responsible for advocacy related to CLM perspective. So it has to be not only by a particular kind of an organization, but collective of individuals, including community members, including healthcare providers, including government officials, who comes together and look into the system, look into the data, look into the real-time monitoring and act upon it. The other thing is that very strong partnership with community activists, government, healthcare facilities, policymakers who are engaged into this, and how do they see CLM data? Do they see any changes that needs to be done within the current policies? Creating constant dialogue, following CLM toolkit as a science, particularly, and keep CLM toolkit as a live toolkit, to keep changing it, to keep adapting it, especially for the communities like women in sex work, transgender people, who are sometimes do not get counted into the general population, and also people who are injecting drug use, right? They are also facing a huge amount of impact into community. The most important thing that I want to highlight is that giving back to the community. So the CLM is not about for us that, okay, we do the CLM and that's how the CLM is get imparted into the communities. But whatever data that we gather from the CLM, it is very important that from whom you have collected the data, you have to go back to them. You have to share that data with them. And we need to constantly develop those mechanisms where communities are not just a data point for us, but communities are the equal partners who understand what CLM is and act upon it. And the last important thing is about, of course, having active advocacy engagement program on HIV services. So constantly looking at the short-term outputs and larger outcomes that CLM is trying to convey from the country. So over the period of 1 year, 2 year, what changes CLM has managed to establish within our key population is something that we have to constantly look at the facility level, at the community level, and at the also level at the country level and regional level, at the high level, where we can demonstrate a clear-cut social impact when it comes to CLM principles. So next slide, please. This is my last slide, and these are the larger ethical considerations that we are right now focusing around when it comes to CLM engagement. One of them is that the CLM activities that community get engaged in has to be from the voluntary participation. The community should understand the data that they are giving, how important that data is, and we can look into other important aspect which has been written over here. But the last thing I want to talk about is that we should make sure that it doesn't harm. It doesn't harm to the people, to the communities, and to the participants who are engaging in the CLM perspective. Thank you so much, Selvan, for the opportunity for sharing the SKPA2 program, and back to you, my friend.
Thanks, Sabina. That's wonderful presentation about the CLM sustainability. Without further ado, I would like to invite Yadvendra Singh, who is actually going to talk about the advocacy message and creation of effective online advocacy message. Yadvendra Singh is the founder member of the community-based organization, Pahal Foundation in India. He played a vital role in organizing various queer events such as Firebox to empower the LGBTQI community. He was also a CCM member under the Ministry of Health and Family Welfare in India. He has vast experience working with CBOs and NGOs. Yadvendra Singh, over to you. Thank you.
Thank you. Thank you, Selvan, thank you, Abina, and thank you, APCOM, and all the partners for giving me this opportunity to talk about the messages. How to develop the advocacy messages, what are the key points that we have to consider. So here's a presentation. So the topic is the advocacy message and the creation of effective online advocacy messages. So moving ahead, can we have the next slide? Yeah. So this have taken the goals of advocacy on CLM, as we all have seen in all the previous presentations, basically to promote the integration of CLM, the use of CLM results to influence decision-making and policy change, and build committee leadership and ownership of CLM. And here, when we develop the messages, advocacy messages around CLM, it is very important that whatever approach we take, the approach, we have to make sure that the key populations are at the heart of what we do. Key populations, MSM, transgenders, FSW, IDUs, PLHIV, they are at the heart. We have to consider their point of view, whatever messages we are developing. And these messages have to be, needless to say, they have to be innovative, compelling, dynamic, and effective messages. And they have to be relevant for key populations through differentiated service delivery. So it is whether it is for different PLHIV group, or we are talking about the trans group, we are talking about MSM groups, IDUs, FSW. So we have to tailor the messages as per the need of the community. Thank you. Next slide. Can we go to the next slide? Okay. So when we develop the messages, the first thing is very important that we have to start with idea. Idea, when I say idea, then it is the identification of the advocacy priorities. What exactly is the priority? Is the government reluctant to buy CLM? Is committee not able to understand what are the priorities of CLM? Are stakeholders able to understand the importance of CLM and how to integrate in their programs? Same goes with the committee. So that is the idea that we need to have. What are the priorities for the advocacy? We need to understand that accordingly we will develop the ideas. So first thing is, we have to understand that there are three components to it. First is, when we develop any messages for advocacy or for any other purposes, we have to do, the first step is we have to do a research on that. The second is about, we have to develop a theory of change around that particular message. And then it is the whole when we talk about the research, we need to know what are the issues.
Hello, Yadwindra, I think your network is not stable. Hello. Hello.
Situation and the target audience. What is the need and the use of the media, especially when we talk about it. So that could be the issue. Then we need to understand what is the situation and the target audience. What are the needs? I mean, what are the reluctance? We need to understand that why the government is not able to understand that, okay, why they're not able to take up the issues of CLM. After that, we need to develop a theory of change. Why and how this is going to differ. Suppose we develop a certain message, how effective is going to be that message? How can we use the media and communication more effectively? And besides, if we are targeting the government, then who else should be working with? Should we invite bilateral agencies? Should multilateral agencies be part of that? This thing that we need to work out. And then it is the communication framework. We need to bring everything together. Whatever research we have done in the communication framework is going to be the roadmap, is going to be the living guide for us, and it will contain everything. You have to develop the planning, information, decision for everyone to understand what has been the project's journey. Can we have the next slide, please? I just got a message. Am I audible? Because it says that my network is not very stable.
Yes, now it's audible.
Okay, now it's audible. Thank you. Okay, so when we develop advocacy messages, the theory of change is very important. We have talked about a lot. Bringing it all together is the next step, but how to develop the theory of change? So advocacy messages, they play a very, very important role. So when we develop any kind of theory of change related to messages, there are certain assumptions that we need to make. The first thing is, when we develop any kind of messages for fostering an enabling environment for CLM approaches to thrive, we need to know the target audience awareness. Whether we talk about policymakers, we talk about donors, local communities, general public, they may not be fully aware of the benefits and the potential of the company-led monitoring. So that is one. Second assumption that we can make is informed decision-making. Whenever key stakeholders are presented with the compelling and evidence-based information that we have also talked about in our previous presentations, they are more likely to make informed decisions that will support the CLM process. Next thing is that advocacy messages have to appeal to the emotions, values, and personal connections, that how this particular CLM method is going to affect the community. So there has to be emotional messages, some personal connection to the messages that could resonate with the audience. And last assumption that we could make is the power of collaboration. Collaborative advocacy efforts involves various stakeholders who can amplify the messages and increase the reach of the advocacy messages. Next slide, please. Okay, so next is the pathways of change. How this, so when you talk about the pathways of change, the first, as you talked about, is the research and evidence gathering. Conducting thorough research and gathering evidences to showcase, I mean, there are some of the country partners who have done this. So that will form the basis of your advocacy messages. Then comes all about the message framing. Crafting advocacy messages that will focus on the benefit of CLM, like how the CLM is going to increase company ownership. How is it going to pitch in for the sustainable development? How is it going to pitch in? How is it going to achieve the goal of the SDG that we are planning? The social cohesion and the resilience. The messages should be tailored according to resonate a specific target audience. So whenever message is there for stakeholder, the same messages cannot be for our target audience. So we have to tailor those messages. Next is about the storytelling and personal narratives. So storytelling and personal message narratives will highlight the real life examples of companies that have successfully implemented CLM, as we have seen in the presentations. Then we talk about the media engagement. So not only digital, but also print and the broadcast is very, very important to disseminate. Of course, digital media reach is unbelievable. And then we talk about the policy engagement, engaging with the policymakers, decision makers through meetings, briefings, and some of the country partners have done that to present the evidence and advocate for the supportive policies. And next is collaborative advocacy, forming partnership, coalitions with like-minded organizations, just not restricting to community-led organizations, but also we can reach out to NGOs, to other community groups that can create a unified efforts for CLM. Next slide, please. Yeah, so the expected outcome from this theory of change is like the increased awareness about the benefits and importance of CLM, increasing their understanding of community-led approaches. Second is the policy, supportive policies. If the government is not very willing to take up the CLM, perhaps through these messages, when we develop these processes, we can engage policymakers, advocacy messages, and can influence development of policies and regulations that would promote and support CLM initiatives. Then we have empowered communities. As awareness grows, communities may feel empowered to take the lead in managing their resources. Then we have the funding support. And there is a shift in attitude. Because once the advocacy messages that will appeal to the emotions and the values, it will create a very positive shift in public attitudes towards supporting community-led initiatives. Next. Yeah. So, I mean, the whole crux was that the potential of well-crafted messages is very important to carry out meaningful changes. Evidence-based storytelling, framing, collaboration with key stakeholders will not only raise the awareness, but also will influence and garner more support for the country-led monitoring systems. And the messages should resonate with the audience. It should lead to informed decisions and actions, and thus leading to empowerment and sustainable development of the communities. Next slide. So before we end, we have to understand that once all this work is done, the live practical work begins. And it is not that once the messages are developed, our work stops. No. It requires constant adaptation. So we need to understand at what stage of the project we are. And then accordingly, if the government initially was reluctant to adopt CLM, then perhaps our advocacy messages would require the government to get them convinced to understand the CLM and adapt it. And once the government adapts it, then perhaps our messaging would change to make sure that now the government becomes a very important stakeholder that will amplify and will make sure that CLM is reflected in all the policies that they make for the key populations and for PLHIV people. Next. Yeah, that was the last, and thank you so much. If there are any questions, please let me know. Thank you.
Thank you so much, Alvindra. It's lovely to see how to create an effective advocacy message, especially for the CLM intervention program. Actually, we are running out of time. If anyone has any questions before the last session, please feel free to drop it and the speaker might answer your question. But before closing the session, I would like to request you all to on the video if you're comfortable with that. This is for the photo session. My colleague Vanis will click the photo, and please on your video so that we can see your beautiful face and we can click the photo if you don't mind. Yeah, and this of course will go on the social media. Hope you don't mind. If you have any problem, please let us know. Otherwise, it's fine. Vanis, over to you for clicking the photo. 1, 2, 3. Page number 1, right? Look at the camera, please. Next page, 1, 2, 3. Again, please look at the camera. Last one, 1, 2, 3. Thank you. Thank you so much. I would like to end the session by saying that even though this is the last webinar of the capacity strengthening activity of APCOM-led, I would like to say that this is not the ending. This is just the beginning. I, on behalf of APCOM, the 7 Alliance Consortium network, would like to thank everyone, and would also like to say that we would continue building the capacity of the communities, particularly on the CLM intervention program, because that's our goal and that's our motto, to ensure to establish a strong and sustainable mechanism at the country level. Having said that, I would like to thank all the speakers, Ika from Youth Lead, Dawn from UNAIDS, Dhanraj from Lexum, Sim Sofal from CNP+, and Leslie Bola from KPACPNG, Abina from APCOM, Yadvendra Singh from Pahel Foundation. Thank you so much. I would also like to thank my colleague Surya One is Nikki, who provided IT support for this webinar. And, I would also like to thank UNAIDS RST team, who was being like the backbone of this and supporting us, for the conduct of the CLM webinar. And last but not the least, about the participants. Thank you so much who joined us in this webinar and have learned. So after this session, we are going to actually share the presentation to all the speakers and also the video to you all. Thank you and have a good day ahead. Thank you and see you all. Bye.